Welcome back to Getting Understanding with Dr. Daryl Ellis. One of the hot topics that we're facing right now in the medical industry and in the medical profession is menopause. Over 50% of the population of this country are women. And those women, as we go through time and we see baby boomers aging and even now Gen Xers aging, menopause is a real issue, both menopause and perimenopause. Been a lot of discussion about it, not only because it's a almost inevitable consequence of aging in women, but also because there's been a lot of false narratives about the best way to approach it, the best way to treat it, and in many cases, the best way to even prevent some of the long-term complications of menopause. I'll talk about each of those individually later, and we're going to break that up into segments because it's very comprehensive. There are dietary approaches, there are approaches with respect to supplements, whether they be hormonal or non-hormonal. Exercise interventions can be very important, making sure you're getting plenty of sleep, and that unfortunately is one of the things that menopause can interfere with, is your regular sleep patterns. So let's talk about it. Let's see whether or not we can come to a conclusion to break some of the myths, break some of the stereotypes, and break some of the barriers that have had women in this country, and frankly all around the world, suffer unnecessarily. When we start talking about menopause, we need to talk about first what it was that we were informed as medical professionals what the proper approach was to treat menopause. Over many decades, what most practitioners would do when a woman would come in with menopausal symptoms is put her on a synthetic form of estrogen called Premarin, which is derived actually from horse urine. Later on, there was a lot of studies that were performed, but one in particular, beginning in 1991, ending all the way in 2005, called the Women's Health Initiative. That was a study that looked at both the benefits and supposedly the risks of exogenous, or if you will, external estrogen replacement therapy on women. And that study was actually stopped prematurely because as they were conducting the control group versus the group that was actually getting the estrogen, they started noticing increased rates of cardiovascular disease, myocardial infarction, as well as increased risk of malignant neoplasms of the breast and uterus. They stopped the study saying that estrogen replacement therapy was harmful to women. That study then was sent out into the medical community, myself included, and most of us practitioners, including OBGYNs, primary care physicians, started taking women off of estrogen replacement therapy, thinking we were preventing them from suffering deleterious effects or potentially lethal consequences. However, about 5 years after the end of that study, additional study was performed on the data set that formed that Women's Health Initiative. After further review and extrapolation of the data, it was found that just the opposite was the case. When we had women who suddenly lost their ability to produce their own estrogen, and we did not allow replacement therapy to take place, we actually saw that there was a significantly increased risk of cardiovascular disease in those women. Prior to women going through menopause, it was a well-known fact that women had much lower risk of cardiovascular disease than men do. Once they go through menopause, we see that that ratio starts to equilibrate, meaning that their risk goes up to that of what men had all along. We thought that it might be related to increased use of tobacco in women. We thought it might be related to women being more in the workforce and having increased levels of stress, but it turns out that it really is related to the loss of the estrogen. In addition, there really is no significant data that shows that estrogen replacement therapy, when performed appropriately, increases the risk of breast cancer in women. So all of what we thought we were doing right actually turned out to be just the opposite. So now there's a change. There's a change in the thought process, both on the primary care level as well as in the specialty care level, in terms of addressing and identifying both perimenopausal and menopausal symptoms as early as possible so that we can get women on the appropriate levels of replacement therapy using careful monitoring and management to be sure that we have them in a proper balance as opposed to just throwing a prescription at them at a standardized dose and hoping for the best. Stay tuned for more.